Have you ever wondered why you give an eye drop before an eye ointment? I mean, really thought about it? Or how a tiny little drop in the eye can somehow affect the entire body? Well, in this explainer, we're going to visually break all that down. We're diving into the essential pharmacology of eye and ear meds, giving you a super clear, exam-ready understanding of how these powerful drugs work and, most importantly, how to use them safely. So, here's our game plan. We'll start with the absolute basics, safe administration. Then we're tackling the big one, glaucoma, and we'll visualize exactly how these drugs control eye pressure. After that, we'll look at some other key eye meds, get the technique down for ear medications, and we'll wrap it all up with a rapid-fire review of the biggest safety alerts you absolutely have to know for your exams and your practice. Let's get into it. Okay, first things first. Before we even think about which medication we're giving, we have to talk about technique. Seriously, getting the administration right isn't just about checking a box on your to-do list. It is the absolute foundation of patient safety. One wrong move can turn a helpful medicine into a really harmful one. So let's kick off with a classic scenario, one you'll definitely see. You walk into a patient's room and you've got both a liquid eye drop and a thick eye ointment. They're both due at the same time for the same eye. So, what's the right order here? Just think about what they're made of for a second. The answer is you give the eye drops first. Every single time. And the why is just simple physics, really. The eye drop is a liquid, right? It needs to be absorbed by the eye tissues to work. The ointment, on the other hand, is this thick, oily barrier. So if you put that ointment in first, the drop would just slide right off. It would never even reach its target. So remember, drops before ointments. And you gotta wait about 5 to 10 minutes in between to let that drop get fully absorbed. Okay, let's walk through this together, step by step. First, obviously, wash your hands and put on gloves. That's non-negotiable. Now have your patient tilt their head back and look up at the ceiling. With a clean finger, you're going to gently pull down their lower eyelid to create this little pocket. That's your target, the conjunctival sac. You'll drop the medication right in there, and this is key. Make sure the bottle tip never, ever touches the eye itself. We don't want any contamination. Then have them gently close their eye. No squeezing. And that brings us to the last and maybe the most important step. Functional occlusion. This little technique is so crucial. You just apply gentle pressure with your finger right to the inner corner of the eye, where it meets the nose. Now, why do we hold this for 30 to 60 seconds? Because you're literally blocking the entrance to the nasal lacrimal duct. Think of it like a little drainage pipe that leads from the eye straight into your body's main circulation. By blocking it, you keep the medicine right there in the eye where it's supposed to be, and you stop it from causing serious side effects all over the body. You know, that technique is the perfect lead-in to our next topic, glaucoma. Now, don't worry about memorizing a bunch of drug names just yet. I want you to picture glaucoma as a simple plumbing problem. That's it, a plumbing problem inside the eye. Once you see it that way, the medications are going to make so much more sense. All right, here's the best way I know to understand intraocular pressure. Just picture a sink, okay? The eye is always producing a fluid called aqueous humor, and it's also always draining it away. In a healthy eye, that faucet and the drain are in perfect balance. But with glaucoma, something's wrong. Either the faucet is turned on way too high or the drain is clogged up. Either way, the sink starts to overflow. Pressure builds up, and that's what damages the optic nerve. So let's give our sink parts their proper names. The faucet in the eye is a structure called the ciliary body. Its job is just to make this fluid. The drain is this spongy tissue called the trabecular meshwork, and it lets the fluid drain out. Simple as that. Every single glaucoma medication we have is designed to do one of two things: mess with the faucet or mess with the drain. Let's start with our first tool, beta blockers, like timolol. This is a go-to for glaucoma, and its job is super simple. It just turns down the faucet. It works on that ciliary body and tells it to produce less aqueous humor. Less fluid coming in means less pressure building up. It's really that straightforward. But remember that punctual occlusion technique we just talked about? This right here is exactly why it can be a lifesaver. If these beta blocker drops get out of the eye and into your bloodstream, they don't just stay local. They can slow your heart rate way down, drop your blood pressure, and even constrict your airways, which is incredibly dangerous for anyone with asthma or COPD. And that leads us to a massive, you have to know this exam alert. The key takeaway is this: you have got to monitor vital signs, especially the pulse, for any patient on these drops. If their pulse is 60 or less, you hold that medication and you call the provider. period. This isn't just a test question, this is a huge patient safety issue. Okay, so we've seen how beta blockers can turn down the faucet. But what if the problem isn't the faucet at all? What if it's the drain? Well, that's where our next class of drugs comes in. Miotics like pilocarpine work to unclog the drain. What they do is constrict the pupil, and that physical action literally pulls on and opens up that trabecular meshwork, increasing the flow of fluid out of the eye. It's like using a tiny little plunger to get things moving again. So glaucoma's a huge piece of the puzzle, for sure. But our ophthalmic toolkit has a lot more in it. Let's do a quick run-through of a few other major classes of eye medications that you are guaranteed to encounter. All right, here's a quick cheat sheet. For anti-infectives, think of it this way. You wouldn't put a Band-Aid on a dirty wound, right? You have to gently clean away any gunk first so the medicine can actually get to the infection. With anti-inflammatories, like steroids, you gotta be careful. Yeah, they're great at tamping down inflammation, but they can also hide the signs of an infection, and believe it or not, can sometimes even raise eye pressure. And for topical anesthetics, the numbing drops, safety is everything. The eye's natural blink reflex is completely gone, so you have to protect it with a patch until the feeling comes back. Okay, next up, mydriatics. The classic example you'll hear about is atropine, and their job is the complete opposite of the miotics we just talked about. They dilate the pupil, making it way bigger. This is super useful for getting a good look at the back of the eye during an exam or for prepping the eye for surgery. But this very simple action creates a massive risk for one specific group of patients. And here it is. This is a huge danger zone, an absolute no-go. Let's think back to our sink analogy to understand why. When a mydriatic dilates the pupil, the iris tissue literally gets bunched up around the edge of the eye, and it physically blocks off the trabecular meshwork. It completely clogs the drain, causing this sudden, sharp, and really dangerous spike in pressure. You can actually trigger an acute glaucoma attack. All right, let's switch gears and pivot from the eye to the ear. The good news is a lot of the same principles apply. And just like with eye drops, the absolute key to making sure ear medications work and are safe is knowing the correct administration technique. Now this right here is one of the most commonly missed skills on nursing exams. The goal is so simple. You just need to straighten out the ear canal so the medicine can get all the way down to the eardrum. For adults and kids over 3, you pull the outer ear, the pinna, up and back. But for infants and toddlers under 3, you pull it down and back. Just remember, up for grown-ups and down for the little ones. And while we're on the topic, let's talk about irrigation real quick. This is a critical safety warning. If you have any reason at all to think a patient might have a perforated eardrum, maybe they had a recent injury or you see fluid draining out, you do not irrigate that ear. If you do, you could push fluid and bacteria right into the sterile middle ear, causing a really serious and painful infection. Okay, we have covered a ton of really important stuff. So now it's time to lock it all in. Let's finish up with a quick review of the absolute must-know safety concepts. These are crucial for your exams, and honestly, even more crucial for your patients. All right, first question, let's see what you remember. Your patient has a known history of glaucoma. They're about to head to surgery, and you see an order for a pre-op eye drop designed to dilate their pupils. Which medication name on that order should make you stop in your tracks and call the provider?
Atropine, or really any mydriatic. We just talked about this, but it is so important it's worth saying one last time. Mydriatics dilate the pupil, which physically slams the door shut on the eye's drainage system. For a patient who already has glaucoma, this can cause a fast, painful, and sight-threatening spike in pressure. It's a true medical emergency.
And for our last thought today, look, knowing all the pharmacology is one thing, and it's essential, but it's only half the job. The other half is taking that knowledge and turning it into real-world patient safety. So, the question I want to leave you with is this. How are you going to empower your patients to not just take their meds, but to really understand why they're taking them and how to do it safely when they get home? That right there, that's not just good nursing, that is the heart of what we do.